Right. Okay, then just a couple more examples. In each of these examples, I'm trying to bring out some of the aspects that maybe makes public health interventions potentially different. This was looking at a mass media-led anti-smoking campaign, and I got quite a shock when I looked, back. It was 21 years ago that I published this study. At least you were all born, that's good. Well, maybe not all of you. Maybe the Caberman wasn't born. Right, 1997. Different world back then. Smoking was even more popular then than it is now. I've noticed walking around Kyoto in the street, I don't see people smoking or indeed vaping. But then I go into a restaurant and suddenly everyone's smoking.
Because a few areas it's not allowed.
Oh, so it's not allowed in public in the street?
There's smoking.
Yeah. Well, I noticed in my hotel there's a sort of death cubicle just beside reception where you can walk in and smoke. So in the street you're not allowed to smoke?
Usually people don't smoke. I was going it's getting more strict in Japan.
Oh, right. Okay.
Smoking is
Right. Okay, well, there's been policies to try and reduce smoking for a number of years in Britain. This one was a study, an intervention in Scotland, and it was an example of a complex intervention. So the intervention had these elements. There was mass media advertising, particularly television adverts, and also posters and adverts in the newspaper or press. To this day, I can still remember many of the posters. They had one where they had a cigarette and a bullet, and the bullet, it said fast and cigarette slow, as a means of killing yourself. Another poster they had was a trolley in a hospital and a sign saying, reserved for smokers. This bed is reserved for smokers. So it was an attempt to be quite hard-hitting. Some of the TV adverts had a sort of tearful mother lying in bed looking very ill, pleading with her son, don't be like her, don't smoke. So it was a real attempt. These days we take it almost for granted that advertising will be a bit more sort of aggressive. But at least back then in Britain in the 1990s, it was quite unusual to take this much more powerful line in trying to persuade people to stop smoking. So there was the advertising, and part of what they were advertising, part of it was the evils or dangers of smoking, but also they're advertising a helpline called Smoke Line. And so this was a free telephone service where you could phone up and get support, advice about quitting smoking. And as well as the free helpline, if you phoned the helpline, one of the things they offered you was a specially designed booklet, so information, called You Can Stop Smoking. And this booklet was providing practical advice and encouragement to stop smoking. So complex intervention, if it worked, you couldn't really say, was it the TV adverts, was it the posters, was it the free helpline, was it the booklet? There was a follow-up of a random sample of those who called the Smoke Line, and almost 1,000 people were followed up. And the primary outcome was estimated as quitting with the direct help of Smoke Line. So the people that were followed up had contacted Smoke Line, and they were followed up over time to see if they gave up smoking. And estimates of cessation or giving up smoking was based on self-report at 12 months later. As is quite standard with economic evaluations of smoking cessation, it's not enough to know how many people gave up smoking. You could calculate a cost per quitter, a cost per additional person quitting, but how much should we be willing to spend to get an additional person to quit? So, in economic evaluations of smoking, or smoking reduction, there's usually an attempt to try and link giving up smoking to the health benefit. And so you need a model to predict the impact on people's health of smoking cessation. And in this study, we used a model, Dutch model, which looked at various risks individuals were exposed to for things like cardiovascular disease, and estimated what part of that risk was due to being a smoker. And so what part of that risk would change if you could turn someone from a smoker to an ex-smoker. And so the model allowed for the changes in survival as a consequence of giving up smoking. What it didn't have was any impact or any attempt to measure reduced morbidity. So it's quite clear at the outset we're missing part of the benefit, because of course the benefit from smoking cessation is not just a reduced risk of death, it's a reduced risk of various morbidities. Another problem with this study was we couldn't estimate how many people would have managed to quit anyway. So we follow up people who contacted Smokeline, and we make an estimate of how many of them have quit. But what we don't know, so it's another example of the attribution problem, and as I say, the attribution problem is a really big problem when looking at public health interventions. What we had to do was make an assumption about how many of them would have quit anyway. It's a bit like what I was talking about with the speed limit, where there's a background change taking place in the casualty rates over time. Well, similarly, with smoking cessation, there's a background quitting rate. People are giving up smoking over time. And the rate at which they're doing that is really important for an evaluation such as this, because you're going to compare the quit rate in those who contacted Smokeline with this background rate. Another assumption, there's so many weaknesses in this study, it was, as I say, 21 years ago. Another assumption was that the only people to benefit from this intervention are those that contacted the Smokeline. But of course, it's mass media led, and so there's a wider population who see the posters, see the television adverts, but don't actually contact the Smokeline, the helpline. But some of them, their behaviour may also have been influenced. So there's possibility there. I haven't written it down here. There's another problem. Interestingly, a large proportion of those who contacted the Smokeline were not smokers. They were the children of smokers. And so a large number of children phoned the helpline, as it were, on behalf of, or they hoped on behalf of, their parents. Now that is quite hard to evaluate, because we then don't, how many of those children would have been able to then convert the parents into non-smokers? We don't know. So quite a few challenges, but despite all that, it did look fairly cost effective back then. By contrast, the second smoking cessation example, I'm sorry I'm pushing all my own work today, that's just, yeah, it's unfortunate, but it's easier to talk about your own work because you can kind of remember it. Other people's, you don't always remember the details. So a big weakness in that smoke line evaluation was we're having to assume what would have happened in terms of quitting if they hadn't been exposed to the smoke line. Alternative here was smoking cessation supported by text messaging. So people in their phone would be getting messages. In fact, they were getting a very high rate of messages. I think there's a danger you would just sort of go crazy. But anyway, they got phone messages. So the trial was called Text to Stop, a good trial name, and it randomized 5,800 individuals to either having the text message support for quitting or not. And what we found with biochemical verification at 6 months. So if we didn't we didn't rely on self-report. We actually biochemically verified by testing saliva whether these individuals had stopped smoking. And we found text messaging doubled the quit rate. Now, we can say that because we're able to randomize. So we don't have to worry about making an assumption about a background quit rate because we've got a control group. The control group, we assume, are quitting at the rate that the intervention group would have quit if they'd not been exposed to the intervention. For the economic evaluation, we looked at cost per life year gained and cost per quality. Quality just the life year gained using a Markov model. We don't have to go into that. Now, economic evaluation always faces at least a twin challenge of obtaining a robust estimate of the treatment effect. That's always a big challenge, but that's overcome here because we've got randomization. So we're pretty sure about this doubling of the quit rate. But the second challenge remains modeling the incremental benefits as a consequence of the treatment effect. So as a consequence of people quitting, what are the health benefits? And so we then have to generate this model that allows us to predict reduced future events, reduced stroke and things like that. Now, this sort of randomization is not generally feasible for most public health interventions. And so we're in a much harder territory usually.